So our topic for today is presbyopia, in which we are going to cover near addition methods. So as we all know that presbyopia is a physiological condition which occurs at around 40 years of age, and it is a gradual process that continues to worsen until the age of 65. So presbyopia is the gradual loss of eye's ability to focus on nearby objects. Presbyopia happens mainly for three reasons: decrease in lens elasticity, second is normal lens growth, and third is increasing lens hardening. Symptoms which are faced by the patients are asthenopic symptoms, difficulty in doing near tasks, and longer working distance to see clearly. What are the risk factors of presbyopia? Age is the most common risk factor: hyperopia, cardiovascular disease, diabetes, and multiple sclerosis.
Now we'll see the basic history of presbyopia. So first we have Benjamin Franklin, who was struggling with changing distance and near glasses. So what he did is he cut the lenses in half and joined his near glasses with the distant glasses, creating the first bifocal lens. Then we have Franciscus Donders, who have given age-based norms by calculating how much accommodation we lose every decade. And then we have Owen Aves, who have designed the progressive addition lenses.
Next, we have the treatment. So, the primary goal of the treatment is to compensate for the inability of eyes to focus on nearby objects. So, this can be achieved by prescribing a suitable plus power lens to bring the objects located at closer distances from the eyes to sharp focus on the retina, providing clear near vision. So the plus power then added can be given in the form of convex lenses, either in spectacle or contact lenses, by undergoing refractive surgery or getting lens implants for presbyopia. So to decide a suitable plus power, clinically known as presbyopic near addition power, to obtain clear and comfortable near vision, different methods can be used. The various methods are tentative aid based on age, increasing plus power based on existing accommodative amplitude, near duochrome test, fuse cross cylinder test, NRA or PRA test, and dynamic retinoscopy.
Now we know that presbyopia starts at age 40 and worsens at by the age 65. Now at age 40, what happens is new lens material is created, older lens material is pushed towards the center, and and the peak of this happens after the age of 40, and amplitude of accommodation drops from 15 to 20 diopters to 3 to 4 diopters. Then at 65 or after 65, the process of lens growth stabilizes, and amplitude of accommodation becomes zero. This may be and after this there can be reasons like cataract, constant near aid, and pupil becomes smaller with age. So first method is presbyopic aid by accommodative method. So step one is we have to know the reading distance. So the reading distance is 40 centimeters. So working distance will be 100 upon 40, which will be 2.5 diopter. Step two is we have to perform the NPA and get the accommodative amplitude. So if NPA is 33 centimeters, amplitude of accommodation will be 100 upon 33, which is 3.03 diopters. Now the rule is 50% of this amplitude is kept as a reserve, and so only 50% is required for near work. So 3.03 diopters, 50% of this will be plus 1.5 diopter. Then we have formula tentative aid. We have to do step 1 minus step 2, which will be 2.5 minus plus 1.5, which will be equal to plus 1 diopter. And we have to put this in front of the eye and ask patient if we can read the N6. Now we will be refining the power. So whenever we are doing any presbyopic refraction, the distance should be corrected, and we have to perform NRA PRA. NRA we are using plus lens, PRA we are using minus lens. So if we get NRA is plus 1.25 diopter and PRA is minus 0.75 diopter, now to refine the aid we are using a formula NRA plus PRA divided by 2. So if NRA is 1.25 plus minus 0.75 divided by 2, so it will be plus 0.5 divided by 2, which will be equal to plus 0.25. So final refined add value will be tentative add plus refined value, which will be plus 1 plus 0.25, which will be equal to plus 1.25 diopter. Then we have tentative add based on age. If patient cannot read N6 at normal working distance, that is 40 centimeter, so there are different norms given at different age: 40 plus 1, 45 plus 1.5, 52, and more than 55 2.5. Different textbook has given different values according to age. So patient's distant power should be corrected. Let's say we have age 42, so the near add we have to put plus 1, and if patient says it cannot read, then we have to increase it in 0.25. So plus 1.25 patient can read N6 comfortable. Then we are increasing then we have increasing plus power. So distance correction we have plus 3 minus 1 at 90. So we have to place this in the trial frame and ask the patient to hold near chart at working distance, and we have to put near add in 0.25 steps. So plus 0.25 plus 0.5 plus 0.75 and plus 1. We have to increase it until patient gain N6 on reading chart.
Next, we have the near duochrome test. So, clinician use the near duochrome test to find the near point of vision by comparing the letters on red and green background. Green focuses in front of the retina and red focuses behind it, assuming the correct distance prescription is in place. Okay, the test uses optotypes on red and green backgrounds, and the patient views the chart at their normal reading distance, and spheres are added until clarity is balanced or slightly green biased. Okay, if the green is sharp, we have to undercorrect, that is add plus lenses, and if red is sharp, overcorrect or decrease plus lenses. If letters on red background are more clearer, the patient is underplused. So if suppose if we add plus 0.5 and the red is still clearer, add plus 0.75 and check if both are equally clear. And if we add plus 1 power, if green is slightly clearer, so we have to assume the power which is we have to give power which is which says that the letters are more clear on both the backgrounds. Next, we have fuse cross cylinder. So in fuse cross cylinder, the, the horizontal lines and the vertical lines are compared. If the horizontal with the distance to perform this test, with the distance correction in place is placed in trial frame, and JCC is aligned with the trial frame at 45 degree, and the red line will be at 90 degree. The subject is instructed to identify which lines appeared more sharp and clear. uh, Adding plus lenses until horizontal and vertical lines on cross cylinder grid subjectively appeared equally clear. If the vertical lines are darker, it needs more plus, so you add plus 0.5. If vertical lines are still darker, add plus 0.75. If the lines are vertical and horizontal lines are both equally dark, add 1 plus 1. And if it gives horizontal lines more darker, then we should consider the power which gives equal darkness in both the lines, which is horizontal and vertical lines. Next, we have NRA and PRA method. So it is another method for determining near aid, which is so basically NRA measures the maximum ability to relax the accommodation while maintaining clear single vision, and PRA measures the maximum ability to accommodate while keeping the single vision clear and single. So to measure this, the clinician uses the patient's distance prescription and a tentative near aid with a point card. So NRA is determined by adding plus NRA is determined by adding plus lenses until the patient can no longer read the fine print, and PRA is determined by adding minus lenses until the patient can no longer read it. The near aid is set by balancing NRA and PRA, which maintains half of accommodation in reserve. So the formula to check the power is NRA plus PRA divided by 2. It will give the near aid power. Next, we have dynamic retinoscopy. So, dynamic retinoscopy is another technique which can be used to determine near aid. With the patient's distance correction in place, put in trial frame, and do the most commonly MEM technique is used. If suppose the MEM technique gives a 1.5 as power, and normally MEM value ranges from 0.5 to 0.75, and the value which we got is 1.5, we have to subtract from the normal power, and the answer that we get is the near aid power.
Next, we have presbyopia treatment modalities. We have non-surgical treatment and surgical treatment. In non-surgical treatment, we have spectacle, contact lens, and pharmacological. In spectacle, we have single vision reading lenses, bifocal lenses, trifocal lenses, and progressive lenses. In contact lens, we have monovision, multifocal lenses, single vision in combination with spectacles, hybrid or modified designs. Pharmacological, we have miotic agent, lens softening agents. In surgical treatment, we have intraocular procedures and cornea based procedures. Intraocular procedures, we have multifocal intraocular lenses, accommodating IOLs, monovision with monofocal IOLs. In cornea based procedure, we have monovision LASIK, presbyopia LASIK, and corneal inlays.
Last year, we have conducted a research in which we found that age-based method was the most used by the optometrist, and they considered it as a standard procedure in which it was less time consuming and more acceptable by the patients. And fused cross cylinder was least used because they face challenges such as time constraint and difficulty in understanding the test. Progressive lenses were prescribed most by the highest prescribed by the optometrist, whereas multifocal contact lenses were not much prescribed by them. 62.3% of the optometrists talked about the ergonomics and teach how to use the glasses, and they asked for yearly follow-up.